Hello, everyone. Welcome to our Unit 7 discussion here in SD 135. So this is our last week that we're going to have a discussion. So you guys are just about done. Our objectives for today are going to be talking about really advanced or specific equipment like microscopes. We've already talked about robots, but we'll also talk a little bit about anesthesia and some stuff like that. So these are also very important in the role of the surge tech because a lot of our cases nowadays require this advanced technology. So here are your assignments for this week, your last full week of assignments. So there are a couple extra, like I warned you about last week, with these comprehensive knowledge checks and final exams worth a lot of points. So make sure you get those in. Don't leave anything empty here towards the end of the quarter. Make sure you get those in. So also this week, you still need to respond to a peer for full credit. Several of you are still not doing that. You're getting, 8 points docked every week. That can add up, especially if you're right on that border of passing. So make sure you get those done. And you have one final discussion post next week, which is a shortened week. So make sure you make good note of this date. It is not your typical Wednesday post. It's a Tuesday. So all assignments really need to be in by this coming Tuesday, by noon Central Time. So that gives me enough time to finish grading everything, finalizing, and getting those sent in. So make sure all assignments, as well as your final discussion post, is due by next Tuesday. Now, this one does not require you to respond to a peer. While you're welcome to, it is not required. So just keep that in mind. You wouldn't have enough time, really, is what that means. But summarize what you've learned, really, in this quarter. Try not to be too short with it. Just be detailed in what you've learned in the last 7 weeks. All right, so let's first start by talking about microscopes. These can be used in a lot of different cases for a lot of different reasons. So there isn't just one type of microscope, of course, right? There are multiple types. Some of them, as pictured here in the top, have eyepieces for both sides, like the surgeon and the assistant. Sometimes there's even a third one on the other side. So that would be draped differently than one with just one set of eyepieces. Like maybe that would be used in an eye case. So here are your specialties that typically use a microscope. Neurosurgery for sure is very commonly using microscopes for brain, spinal cord, very delicate nerve structures. Got to be able to see what you're doing. Ear cases, the surgeon has to be able to see, past the eardrum. It's a very small space. You definitely need that to look bigger. Microvascular surgery, very small blood vessels that might need to be dissected and re-anastomosed. And then ophthalmic or eyes. We use a lot in eyes. So with the microscope, as it's hanging over the sterile field, like I mentioned, it has to be draped. So there are special drapes that go over those. Draping a microscope can be tricky. We'll talk about that. But it also comes with the monitor for everyone else who's not looking under the microscope for them to see as well. Like sometimes as the surge tech passing, you're not under the microscope, you're standing beside like this person is. So you need to be able to see what they're doing so you can anticipate. So this is one version, by the way. Considerations for the surgical microscope. What do you as a surge tech need to know? First of all, obviously handle with care. That kind of goes without saying, but they are super expensive. Some of them in the millions of dollars. And even just maybe transporting it like down the hallway, if it doesn't stay in that room, accidentally bumping it can mess up the optics. Maybe it'll knock something out of alignment. You don't want to do that. Gotta be very careful. Never bumping it while it's in use. I have seen this happen. It is not pleasant. So one time I had a student who was scrubbed in with me in an ear case and just wasn't paying attention, accidentally bumped, the base of the microscope while he was looking inside the ear. And he didn't say anything, which is actually probably scarier, but the surgeon was not happy. And the student didn't come back the next day. So it was not pretty. Be very careful. Surgeons get very irritated sometimes. And you have to realize that they're looking at this small space, but any movement is going to be amplified. It's going to look like an earthquake. So obviously, if they're working on very delicate structures, like, within the brain, for example, you could really do a lot of damage if the surgeon accidentally, moves their hand, even millimeters. So that is important. Now, these lenses that they're using to view with can be changed out for different magnifications. So always check your lenses for the correct magnification. It should say maybe on your preference card, like direct laryngoscopies, we'd always use a 400. I just remember that one off the top of my head. So whenever you go to pass instruments, the surgeon is going to be, right in there looking through the eyepieces. They do not look up every time they need something. It would take them for, it would mess with my head. I know it would, being able to look up and then refocus and look down. So they don't look up. They stay focused on what they're looking at and just hold their hand out and expect you to put in the instrument that they need in the correct way. So you need to make sure that you are passing instruments in a way that the surgeon does not have to reposition their hand to use it. So, and you don't want to bump their hand either. You just want to place it in there as gently and correctly as possible without readjustment. So that does take a little skill, but is definitely doable and something to work. So like I said, draping the microscope can be tricky. I could not, for some reason, get this video pull up while I was doing this, but if you wanted to pause this, copy, paste, type this link in, it's a good video on how to drape the microscope. So I would highly recommend you look at that if you have never seen it done or have done it yet, to give you a heads up as to what you're getting into. So really the important thing when draping anything for that matter is to protect your sterile gloved hands at all times. So the microscope has to be draped while you are sterile because the drape is sterile. And you always want to protect your gloved hands. So you would kind of cuff it over top of your hands as you slide that drape up and around it. Okay. There are also little sticky tabs that will, once you get it on, let you tighten it around the post of it so it's not like droopy or hanging down. And also keep enough slack in the drape to allow for some adjustment. It does like raise lower, as needed. So keep a little bit of slack there. So let's move on to anesthesia. Airway management isn't something we typically do as a surg tech, but it does pertain to us in that most of our patients, have to have their airway managed. But different surgeries, maybe the tube would get in the way versus maybe the surgery doesn't need an ET tube. So it does play a part in what we do. Really, the very important thing about airway management is when the patient is being put to sleep, something can happen called a laryngospasm that can compromise their airway. So that means the larynx or the voice box will spasm and close shut, which means no air can get through. So it becomes an airway emergency. The reason why this happens is one of your last senses to go when you are being put to sleep is hearing. So even though the patient may look asleep, the eyes are not open, they may still have some sense of hearing. And any loud noises can startle them into this laryngospasm. It's just a response trigger. So if you're at your back table setting stuff up and banging things around, that can trigger a laryngospasm. And if they do not have that ET tube, that endotracheal tube in place to manage their airway, the patient will not be able to breathe. So that is definitely a concern. It is a risk. Anesthesia might yell at you if you are banging stuff around while they're trying to put them to sleep. I've seen it happen. Be mindful of that for sure. They can give drugs to try to break that laryngospasm, but it's never guaranteed. You don't want to compromise their airway for sure. So the other thing to remember is the same can happen when the patient is being awoken. The hearing can still trigger a laryngospasm as they're extubating the patient. So when they are being put to sleep and waking up, it is very important that everybody in the room is super quiet. Just keep that in mind. So if you are not sterile, you're not scrubbed in at your back table, but you're maybe free or extra in the room, you should be up by anesthesia, just to be available. Sometimes they need an extra set of hands to hold something while they do something else. You are not intubating, but you can be of some value and help up by anesthesia. And if anything does go wrong, maybe you could even start chest compressions. You are trained to do that. That's within your scope of practice. So different surgeries do require different depths of anesthesia. Not everyone is going to be given that ET tube or endotracheal tube. So general surgeries, the airway has to be managed by anesthesia because we're putting them to sleep, giving them muscle relaxers, which would relax muscles needed for breathing. So airway has to be managed. Now, an LMA is a little laryngeal masked airway, which does not go quite as far down as the ET tube. It does not go into the trachea. It sits on top of the larynx, so it does not go through the larynx. So those are typically for shorter-ish general cases. MAC stands for monitored anesthesia care, which is what a lot of patients will call twilight. If they have ever talked about their surgery experience, that's probably what they would say. They're not fully asleep. They might be knocked out, but they don't require airway tube management. Like they don't need an ET or an LMA for a MAC. They are breathing on their own, and it's typically for shorter cases that don't require a really deep amount of anesthesia. So that wouldn't be good for things like abdominal surgeries or anything in the thorax or brain. Those are big things that require airway management. You could do it for, let's say, colonoscopy, EGD, maybe some cystoscopies, maybe even like some small lesions, something like that. Now, a local anesthesia is usually the patient is fully awake. No airway management is needed. The patient might even be talking to you during the case, which sometimes is a little weird, but that's for really kind of smaller things. Like you could do that for lesions. We did a lot of lesions that way. What else? Some cystos, depending on what you're doing, you could do a cystoscopy with the numbing jelly. So they'd still be awake, but they wouldn't be able to feel the tube in the urethra. So be mindful of tube placement during positioning is another concern for surge techs. Sometimes you do have to help position the patient. Maybe you're turning them from supine to prone. Anytime you do that, always wait for the direction of anesthesia because they are in charge of any patient movement. So you don't move anything until they say that it's okay because they need to make sure that the airway is secured. So you can help with that as well. Another anesthesia complication or something we should be concerned of is called malignant hyperthermia. Note it's hyper, not hypo, hyper. So this is referring to an increase in body temperature, an abnormal increase in body temperature. So this is really due to a genetic defect or a genetic mutation that responds to certain anesthesia drugs. It's a complication due to certain anesthesia drugs. What it ends up doing is causes the muscles to contract sustained. It doesn't break, it doesn't stop. The muscles continue to contract for long periods of time, which is going to release a lot of calcium that stays in the muscle usually, but it's going to be released into the bloodstream, which causes a whole host of problems. A lot of things happen right after that. So it's a pretty quick onset. You typically, once it starts, you start to see the first early signs. You only have minutes to react. So while this is not a super common complication, it is common enough that you need to be able to recognize it and react quickly. Because if you do not react quickly, the patient will die. There's like, I forget what the stat is. I want to say something like 80% mortality rate if you don't respond within 10 to 15 minutes. So that patient will not make it, essentially. So every surgical team member has a role in this treatment for these patients. So you need to be familiar with what your role is, okay, and what the treatment steps are, and where your malignant hyperthermia cart is. Every OR should have an MH cart. If they don't, Maybe if you are currently working in a hospital or in the OR somewhere, go on the hunt and see if you can find it. If you don't have one, or ask around if there isn't one, you maybe put a bug in your boss's ear or something. That is super important. It's life-saving. Okay, maybe smaller facilities may not. I'm not sure. I think all the ones around where I live do, even though they are slightly smaller. So I would hope it's a regulation. But look at some of these signs. So we classify certain signs as early or late signs in malignant hyperthermia. So an early sign, this first one is usually the very first thing you'll ever see. It is increased, which says ETCO. So that means end tidal CO2 or carbon dioxide. So the first thing that they will notice, anesthesia will notice, is an increased level of carbon dioxide that the patient is exhaling. They're breathing that off. So because of what we just said about the muscles contracting, they're doing a lot of work. When cells in general do a lot of work, they release carbon dioxide as a byproduct, as part of that chemical reaction. So it gets put in the bloodstream. Then it's going to go to the lungs and your body's going to try to breathe it off. It's going to sense that there's too much, and then it's going to try to breathe it off faster. So that's where you're going to get tachypnea, rapid breathing. You're going to get tachycardia, rapid heart rate. Acidosis is the condition of having too much acidity within the blood, which is coming from too much carbon dioxide. The more carbon dioxide you have in the blood, the higher or the more acidic it is. It would actually be a lower pH. Okay. Then you're going to start to see muscle spasms because of that contraction, specifically in the masseter muscle, which is in the jaw. Then your late signs typically start with hyperthermia. So the increased body temperature doesn't start till later. That's not typically an early sign. It might be a mid sign, a mid to late sign, but not early. Then you're going to have full body rigidity, basically. And then if you have a Foley in and you start to do urinalysis, you're going to have myoglobinuria, myoglobins in the urine. You don't want that. So obviously they need to rule these other things out first. Anesthesia will do that and they have to do it very quickly. They might adjust something to see if it fixes it. If not, then you have a pretty clear indicator. So the treatment, you for sure need to know, even though you're not anesthesia and you're not administering these drugs, you still need to know them. I can almost guarantee you that when you go to take your certification exam, there will be at least one question about something on this chart. Just one, I promise you. There's always one question, whether it's a sign or whether it's the treatment or what your role could be. So the very, very first thing you need to do is discontinue the anesthetic triggers. So what are those triggers? That's often the question. What triggers MH? It is succinylcholine or volatile anesthetic gases. So those are the gases that end in A&E. Sevoflurane, desflurane, isoflurane. Those are volatile anesthetic gases along with succinylcholine that can trigger malignant hyperthermia. Now, gases like nitrous oxide does not. Okay, so don't think it's all anesthesia gases. It's volatile anesthetics with sucks, right? So obviously the trigger needs to be discontinued. You're going to hyperventilate with 100% oxygen for sure. And then the drug of choice is typically something we call dantrolene or Dantrium, which is its brand name. There are a few more on the market now. One of them is called Ryanodex, I believe. I think there might be one more, but typically we refer to dantrolene as being the drug of choice. You should also know the dosage. It is 2.5 milligrams per kilogram. So however many kilograms your patient is, let's say they're 100, you multiply it by 2.5, that's what your dosage is, okay? Now, dantrolene comes in a vial that has to be reconstituted. It is a powder that you have to reconstitute with sterile water. So one of the jobs that you might have as a surge tech is to reconstitute dantrolene. That is something in your scope of practice. You can reconstitute those for either anesthesia or a nurse or the doctor to administer. Now we cannot administer it. but we can reconstitute because it takes a lot. Um, it takes multiple vials of dantrolene, and they need the multiple vials over multiple days to fully get them like out of the woods. It's not like a one and done situation. It is constant for days that they have to keep giving this. So until they're stable, which could take a while. So those are the first very important treatment steps. There are a few others. Sodium bicarbonate is going to help counteract acidosis. They might even give them insulin. There's a lot of other things that they could give these patients for other reasons. So if they don't treat it, it's also going to affect their kidneys. So there a lot of things can happen very quickly. So you might also have to go get the malignant hyperthermia cart. On that cart, it should tell you what roles there are. There's also a hotline that you can call because it happens so infrequently that you can call this hotline. They'll walk you through it. If you're there like on call at midnight and you don't have any other help, call them. They will help you and walk you through it. Also, you might need to pack the body with ice or get a slush machine that your OR should have. It's going to turn saline into a slush, and you can pack any open body cavity with that. That is super important. That will help keep their body temperature down. It could get up to 107 degrees Fahrenheit if you're not careful, which could kill them very quickly. So you want to pack any open body cavity, put it near pressure points where the blood is towards the surface, neck, wrist, groin, anywhere. You have to keep that body temperature down. Super important, okay? So that is our Unit 7 and technically 8 conclusion here of our discussions. There will not be a discussion next week because it's just that shortened week with the one assignment due on Tuesday. So there will be no discussion video posted, but if you have any questions on any of this or any other assignment as you wrap these things up, please don't hesitate to reach out and I will get back to you as soon as possible. Have a good day. Bye.